Hello, everyone, and welcome to this UCSF Institute for Global Health Sciences webinar, which is produced in partnership with the Bay Area Global Health Alliance. My name is Jaime Sepúlveda. I am the Executive Director of IGHS. This webinar is presenting two case studies, the US and Mexico, that we were invited to produce by the independent panel of the World Health Organization. This is the independent panel on pandemic preparedness and response. We're also streamlining this event on Facebook. We will be moderated in this webinar by host of a Shot in the Arm podcast, Ben Plumley, who is also a senior advisor to the Bay Area Global Health Alliance. Over to you, Ben.
Thanks, Jaime. I'm really honored to be here today. And I know the Bay Area Global Health Alliance is really thrilled to be a part of this. We've got a lot to get our teeth into today. We'll be checking the Q&A function of Zoom and Facebook live stream for any questions you may have, and we'll do our very best to answer as many as we can. We've got an extraordinary panel, and we are going to be posting, I think right now, the bios of everyone in a document onto the Zoom call so that everyone can see who's with us. So let's get right into it. Jaime, can I hand back the floor to you to give us an overview and your sense of these reports?
Happy to do that, Ben, and I will be using some slides for the next 10 minutes to make sure that I cover what we want to say. First, this is the covers. These are the covers of the two case studies. That this is the one for Mexico. This is the one of the US. Let me show the next slide. The summary of the report is in this slide. I led the two Mexico and the US reports, but the people who actually wrote the reports are a fantastic group of people. In the case of the US, Neelam, Feachem, Kelly Sanders, Forrest Baker were the ones leading, but we also had a research team of 10 members. It's an exceedingly well-documented report with over 450 references. We did interview more than 20 experts, including ex-directors of the CDC, ex-Secretary of Health and Human Services, and many other prominent people. We also had external reviewers check out our report before we submitted those to the independent panel. It was a very intense effort over 3 months by 14 people in the case of the US, 9 people in the case of Mexico. The leading author in the Mexico report was Mariano Sanchez, who will be commenting later. Again, extremely well referenced and many experts interviewed. I must say that the report in Mexico was not very well received by the federal government, but it went absolutely viral in social media. I am only going to be able to present some of the conclusions and recommendations because of the sake of time. One of the conclusions is that the federal authority failed miserably to perform their stewardship function, particularly in bringing a coherent and unified national response. These are official figures around the number of deaths directly attributed to COVID. In orange behind, we have the excess mortality, again, recognized officially by federal authorities. But independent studies have shown that the true mortality, both by COVID and excess mortality, must be now over 500,000 deaths. That is twice the admitted numbers. When we compared 39 countries for which we had excess mortality data from the United Nations agencies, we saw that Mexico was one of the 4 countries with the largest excess mortality. Only Peru, Ecuador, and Bolivia had higher numbers. Now, this excess mortality in Mexico was 43%, again, using only official data. If Mexico had behaved like the average of these 39 countries, which was 17% excess mortality, 190,000 deaths would have been averted. Again, if Mexico had behaved like the average country in here. Another conclusion is that the authorities failed miserably again to prepare in terms of protection, personal protection equipment, and as a consequence, health workers were put at a huge risk. As of February 2021, Mexico was the country in the world with the largest number of health workers that have died of COVID, 3,000 by February. Now the number is even larger. Another failure is that related to the large inequities in access and quality of health services. This is, again, official information from the Ministry of Health showing the fatality rate in hospitalized patients. I don't think you have seen this in many places, that in public hospitals, those called here IMSS, Ministry of Health, ISTE, these are the public hospitals. All of them had 40% hospital mortality. In the case of IMSS, which is the largest HMO in the world, by the way, figures close to 60% mortality in hospitalized patients. This is about 3 times larger than in private hospitals. Vaccination, even though lately is starting to improve, comparing Mexico in March 22nd, that was the last time we submitted the information to WHO independent panel, Mexico was having a very, relatively to other countries in the hemisphere, a relatively low vaccination rate. In the case of the United States, there are 8 conclusions and derived recommendations. Some recommendations for the short term, other recommendations for the longer term. And frankly, some of our recommendations are quite audacious, like proposing to have the Centers for Disease Control, the Food and Drug Administration become more independent, perhaps considering the Federal Reserve as a model. With the Trump administration, the US lacked effective political leadership. We can see that in the variance in state responses. These are 3 states, Arizona, California, Washington. Just look at the vast difference in deaths per million in these 3 states. But even within California, looking at 2 cities, San Francisco and Los Angeles, look at the difference, San Francisco in yellow, Los Angeles in blue, in terms of deaths per million. Another finding, similar to Mexico, the huge inequities. When we look at people of color, they were disproportionately affected. if we compare hospitalizations, cases, and deaths by race, ethnic group compared to whites, we see that non-Hispanic people, particularly Hispanic and Blacks, had twice or even as much as 4 times the rates of hospitalizations, cases, and deaths. This has had a consequence in life expectancy. Overall, the US has lost already 1 year of life expectancy. But if you look what happened to African Americans, the loss of life expectancy has been 3 years. In the case of Latinx is 4 years. So another obvious conclusion, the US will not be safe until all countries are safe. This is not a humanitarian issue only. This is a concern of national security as well. So the notion of global immunological equity is something that we are pushing very, very strongly. Our report was submitted in March, and we included in the last edition a postscript to recognize the Biden-Harris national strategy. As you know very well, $1.9 trillion stimulus went into law, so-called the American Rescue Plan Act of 2021, out of which 93 billion went directly to funding public health related activities. You can see that since the change of administration, the vaccination numbers have gone up, 3 million doses in average, and the consequences have been dramatic. Almost perfectly timed with the change of administration, we see the huge drop of cases and consequent drop on hospitalizations and deaths. Just last Friday, The Lancet published a report, an editorial called Recovering from Trump, Biden's First 100 Days. They describe in detail all of the good things that the new administration is doing as a recovery from the disastrous previous administration. I'll stop here and get back to you, Ben.
Well, thank you very much, Jaime. And actually, we have a question that has come in from Melinda Walker, which perhaps you can answer quickly before we move on. And I guess she's talking about the Mexico report. And is it your sense that the private hospitals have healthier patients than the public HMO hospitals?
That is very true. And clearly, it is affluent patients that did not wait so long to get healthcare. So these are people that, one, went earlier to be treated, and two, most likely had better quality of care. Public hospitals became so overwhelmed that people had no chance to access the first hospital. They had to go round and around hospitals to see where they could be admitted. And also, the federal government recommended strongly to people to stay at home and not seek healthcare unless they were very, very sick. So that explains the high mortality in public hospitals. When people finally went to a hospital, they were in very bad shape.
Well, thank you, Jaime. And there's a lot that comes out of your presentation that I hope we will come back to in the panel and open questions at the end. But I'd now love to invite the two lead authors of the reports, Neelam Feachem, who is Associate Professor of the UCSF Institute for Global Health Sciences and the Department of Epidemiology and Biostatistics, who led the report on the US response, and also Mariano Sanchez Talancir. He is an academic scholar, Harvard Academy, Harvard University, and assistant professor, Center for International Studies at El Colegio de Mexico. Welcome to you both. And Neelam, I guess my first question is for you. Everyone has their own opinion of the US's experience of its first full year of COVID. And as Jaime reported at the end of last week, we learned that nearly 144 million people, or 43% of the population, have received at least one vaccine dose. The Biden administration seems to be following a public health informed response, which is reflected in your recommendations. But are there any outstanding recommendations that you would still like implemented?
I guess the short answer to that is yes. The vaccines are not a panacea. There's a lot that we still don't know about the vaccine response. We don't know the duration of protection. We don't know their efficacy against variants. And we also have to overcome some high vaccine hesitancy levels in many communities of color, and also, curiously, among Republicans, as our report found. So the report, as Jaime mentioned, makes a number of recommendations beyond vaccines. And I just want to actually highlight 3 of them. Because while I agree that the Biden administration is following a public health informed response, certainly in contrast to the previous administration, we really need to keep laser focused on public health measures. In the short term, we need to follow the lead of the East Asian countries, which have been very successful in giving more prominence to basic public health measures such as frequent and rapid testing, universal mask mandates. And as we're seeing transmission go down, we can really shore up our contact tracing and put in supportive and enforced isolation and quarantine policies. And I think in the longer term, although the Biden administration has put a lot of money into public health, as Jaime mentioned, we have chronically underfunded our public health system. And that is something that needs really careful thought. And we recommend in the report an infrastructure fund for the next few years to strengthen our public health system. I also think that the other key recommendation in the report is highlighting the unequal access to healthcare services. And this is an area that I spend a lot of time on. So it's clear that we need to join the rest of the wealthy world and guarantee universal health coverage and access for everyone. I think those are really, really important goals. And then finally, as Jaime said, we will not be safe until all other countries are safe. So we need to fight the pandemic as a classic global public good and take a leadership role in COVAX and in supporting a global health architecture so that we really do have, global health security.
Thank you, Neelam. Mariano, your report runs through to the end of 2020. What does the first quarter of 2021 look like for Mexico? And, Jaime was talking about how this went viral, if you'll excuse the pun, and how perhaps the federal government wasn't so happy with the report. But has the government learned anything?
Thank you, Ben. So speaking of 2021, it's true that our report finished until the end of 2020. And so Mexico experienced, especially in January, it was part of the second peak that we observed after the holidays. And January, in fact, we saw very high mortality. Since then, the pandemic has been, where the number of infections and deaths has been going down, although Mexico remains at very high levels of transmission and in an international perspective. And so a lot of the recommendations that we make in the report remain, of course, very relevant. And as Jaime mentioned, the report was not well received by the Mexican government, in fact, probably because it's critical, of course, of the government response. But we believe that many of our recommendations still should be adopted, and it had very good reception among the public health community and the public in general. And unfortunately, I think this response or this kind of reaction to the report is in fact a symptom of something that we highlight in our first recommendation, which is, it really shows the deficiencies in the emergency management model that led to a failure in incorporating relevant scientific evidence and an inability to acknowledge mistakes and to correct policy as necessary. Of course, at the beginning of the pandemic, there was a lot of uncertainty about the disease, but governments had to learn over time. Unfortunately, in the Mexican case, the emergency management model itself, given that it lacked institutional checks to minimize the potential for error and necessary levels of independence from the political sphere, has been unable to make those corrections. So we hope that that will change and that our report is bringing attention to some of the necessary changes.
Thank you. Neelam, a key outcome for me from both reports, but particularly yours, is the reminder that you can't take your foot off the brake when trying to stop the spread of a pandemic like this. So really a two-part question. You talk about rethinking the CDC and the NIH, I guess as part of securing some sustainability and capacity in the United States. Could you talk a bit about that? And then secondly, going beyond the US, I just wanted to get your thoughts about what's happening in India and how you feel we here in the Bay Area can help the people of India.
Thank you. Great questions. So I think some of the things that I mentioned earlier in terms of our longer term recommendations, universal health coverage, stronger public health infrastructure are going to really support sustainability. And then also the issue that you mentioned. I mean, one of the things that our report highlights, and so does the Mexico report, and it's kind of been a universal reality in this pandemic, is that political leadership is critical for an effective national response. And since we cannot guarantee who will be in office when the next pandemic arises, we need to find ways to shield our key public health institutions with a governance model. It may be the Federal Reserve, maybe some other kind of governance model. But also we need to look at what other countries have done legislatively and politically to ensure that the response that is taken is swift and well thought out in advance. And I think we can learn a lot from the East Asian countries in terms of some of the legislative structures that they've put in place. And so I think all of those things will help sustainability. And I guess the final thing is that we have some anecdotal evidence that countries with women leaders are more effective in their COVID-19 responses. So I would suggest that we hedge our bets and ensure that at least half of all of our leaders are women. And so, that will certainly help sustainability. Now to your other question about India. There are two members of what I call the Billion Persons Club. Now, one of them has done incredibly well despite a very rocky start. And the other, which is India and is near and dear to my heart, is in the middle of this really unfolding catastrophe. The pandemic has exposed this extremely fragile and unequal public health and healthcare system in India. And I think many of us who have worked in India or have studied India don't find what's going on surprising. The Indian government spends less than 1% of its GDP on health. And we're seeing the result of this extreme underinvestment. In terms of what we can do, I think in the Bay Area, we can certainly respond to the humanitarian crisis, which is happening right now. We can send materials for vaccine production, oxygen, ventilators, human resources as needed. So I think we're doing a lot and we can continue to do a lot because there is definitely a humanitarian crisis right now. I think on the longer term, though, that we as a educational institution and as leaders in health can raise our voices to push the Indian government to make health a higher priority and spend much more money strengthening their public health and healthcare system.
Thanks, Neelam, and love and light to you for all the stuff that you're doing in mobilizing us all. So thank you. Mariano, I guess I'm going to ask a slightly similar question about building sustainability. But how does Mexico keep your recommendations alive? Where does the report go from here?
Well, I think we make two types of recommendations. Some of them are rather urgent, and are things that Mexico and Mexican policymakers should change as of now to try to contain this pandemic and to slow down transmission, to accelerate vaccination. One important thing to notice is that unlike other countries in the world where vaccination is moving swiftly, including the United States, in Mexico, it's only 10% of the population that has received at least one dose. And this proportion is below other countries in Latin America, like Chile or Argentina or Brazil. So that is something that is very important. So all the public health recommendations that we made to slow down transmission, to contain the virus itself in this pandemic, to accelerate vaccination, which includes bringing in the private sector, civil society in a very large, and this is a major logistical enterprise that the Mexican government has never, or any other country in the world, no one has ever had to vaccinate its entire population in such a short period of time. So all these recommendations are something that we think that should be picked up immediately, including changing the communication strategy, depoliticizing public health messaging. And so I would say that that's a first set of recommendations that still need to be addressed early on. And then the second is really concerned is more medium-term, long-term forces that have really shaped the impact of the pandemic in Mexico that have to do with chronic underinvestment in the public health system, massive inequities in access to health services and in the quality of health services. Jaime already had mentioned that the big inequities that the pandemic has fully exposed with respect to access to care. And in many of these respects, Mexico will need to first invest much more in public health than it does. We think that this is likely going to require some kind of tax reform, a new fiscal contract, so that Mexico can actually fund these policies, universal access to healthcare, and to close these gaps that we have seen in this pandemic. So we need to start thinking about the medium and long-term effects of the pandemic as well, and how this has really transformed and changed the level of demand on health services, citizens' awareness of health needs, and of the possible long-term consequences of the pandemic itself. And therefore, we need to start making those investments now. And our report really divides these recommendations in sort of the short-term and medium and long-term actions that we need to display.
Great. Well, we've got some time for a few questions that have come up. I'll start with one from Sophia Georgiou, who says that we've seen that the COVID-19 pandemic has decimated communities with high rates of coexisting infections and chronic disease. Besides healthcare system strengthening, what can be done across borders to address these underlying factors that will contribute to mortality and worse outcomes for any pandemic? And I guess that's a good question for both of you. And Mariano, perhaps I could start with you on that.
Sure. So this really goes back to we need to prepare for the next pandemic in two ways. So first is really strengthening the institutional architecture to respond to health emergencies. So in any crisis, the first thing that you need is try to avoid people from getting sick, right? And we failed massively in this respect in many countries. So that put enormous pressure on health systems. In Mexico, there's a lot of debate about how the health system was unprepared to deal with an emergency like this. But we need to recognize that no health system would have been in the world would have been able to, absorb the demand created by such high levels of transmission. So the first thing that we need to think about is how do we strengthen the institutional architecture so that when the next emergency comes, when the next pandemic hits, we have the adequate institutional procedures to have a forceful response where leaders respond in the way they have to, and we minimize the number of people that get sick. The second really concerns how do we implement reforms and measures to broaden access to quality health. And in both the United States and in Mexico and elsewhere, what we have seen is that first, pre-existing conditions have exposed certain populations to very severe COVID-19. So we need to address those pre-existing conditions. That means investing much more heavily in preventive medical care, in medical education, really broadening people's opportunity to take care of themselves. And second, to put in place ambitious investment programs. In Mexico, for example, we have a massive problem with a very uneven distribution of our health infrastructure throughout the country. Those inequities need to be addressed so that whenever we have another emergency, or even in routine times, people can have access to healthcare as a basic citizen right. That means resources, that means coordination across health subsystems. Fragmentation in the health system has been very damaging for Mexico as well. So we need to really have a very comprehensive plan that looks at the social determinants of health as well, which means that some of the responses or some of the solutions that we need pertain really to the health system reform, but we also need to implement reforms that lie elsewhere, that lie outside the health system itself, but that are important to address the social determinants of health.
Thank you, Mariano. And Neelam, as you answer this, we got a question from Facebook Live, which I think speaks or ties into this. You know, as well as sort of cross-border collaboration, what kind of associations are hiring bilingual medical staff to take care exclusively of immigrant health needs?
The latter is a great question, and I'm afraid I'm not sure of the answer. I'm not the right person to answer that question, but I think there may be one of your panelists who will be able to address the question of associations that are hiring bilingual staff. But I do want to pick up on the whole social determinants of health issue that Mariano brought up. As we all know, our social safety net in the United States is very, very poor. I mean, for as wealthy a country as we are. And I think that's what we have to focus on. It's not just the health sector, because we actually spend an enormous amount of money, very unequally and inefficiently, but still an enormous amount of money on the health sector. We don't spend a lot of money on social services. We don't spend a lot of money on issues of poverty and hunger, child hunger. So, I mean, these are things that we really need to focus on if we are going to reduce these inequities. So that's really, I think, a very, very important next step for us.
Thank you, Neelam. Well, I guess we're coming to the end of this part of the conversation. So everyone, I hope you'll join me in thanking Neelam and Mariano for their absolutely brilliant work leading these two reports, which I think are going to be profoundly important in driving the next stage to the pandemic. At this point, I would love to welcome and introduce the next panel to everyone. We have, I thought it was going to be alphabetical, but I don't think I can spell. So in no particular order, we have Lucia Abascal, MD, who is a PhD student at the UCSF Institute for Global Health Sciences. We have my dear friend Eric Goosby, professor, UCSF School of Medicine and UCSF Institute for Global Health Sciences. And Eric is also the special envoy, the UN special envoy for TB. We have Mary Pittman, Doctor of Public Health, who is President and Chief Executive Officer of the Public Health Institute. She's also, by the way, the chair of the Bay Area Global Health Alliance Board. And we have Carlos Del Rio, who is a doctor, and he's the Associate Dean, Emory School of Medicine and Grady Health System. He's a professor at the Hubert Department of Global Health, Rollins School of Public Health, and he's the co-director of the Emory Center for AIDS Research. And I should say, as an old AIDS activist, Carlos, I'm one of your biggest fans. And last, and by certainly no means least, we have Jaime Sepulveda back. He, of course, is the director of the UCSF Institute for Global Health Sciences, and he's also a member of the Bay Area Global Health Alliance Board. So, Eric, could we start with you? You have a unique perspective on the global response to pandemics, from HIV to malaria to TB. Why do you think the world has so badly underestimated SARS-CoV-2, the virus that causes COVID-19?
Yeah, thanks, Ben. It's an honor to be part of this discussion, and want to thank Jaime and the authors in the case studies for both the United States and Mexico, which give a very thoughtful and I think helpful discussion of what occurred, and more importantly, what do we do about it? And I think is well worth the reads. I think that Neelam and Jaime have spoken, I think, directly to the lack of a public health infrastructure in the United States and in Mexico that could withstand the burden that COVID rapidly placed on the system. Specifically, it did not, in a homogeneous way, challenge every individual, group at risk or in a country. It, as it does with every disease, favors those that afford an advantage to infection spread and the ability for a delivery system to identify and check that spread, both in the individual and in the population itself. Our experience with COVID, I think, is well outlined in the discussion. The one thing that I would emphasize stronger would be the decentralized the decentralized nature of our healthcare delivery system, and the fact that 93% of our population is insured in third-party payer relationships, insurance companies, etc. The mandate and self-perception that the public health response is part of that portfolio's menu in ensuring that individual was argued about in the United States for weeks to months in the initial engagement around, as was pointed out in the discussion in the pieces, testing was not something that the insured third-party payers thought was part of their responsibility. Indeed, public health was not part of their responsibility in the initial discussion. And the inability to pull it into a centralized discussion narrative that defined unmet need and prioritized it, put it into 50 different state discussions to do that. And those 50 discussions turned into every county in their state having skin in the game and a need to assert themselves, both in the accrual of PPE and in understanding and educating health professionals, physicians, nurses in how to diagnose and successfully treat the disease. Those nuances took weeks to disseminate, and in part, I would say large part, it was confounded by the inability to sit down at a table and have a discussion about a specific population and the threat that COVID presented to it with the individual or entity that was paying for and responsible for the health care of those individuals. So I think this is something that is underappreciated as a central problem that stuttered at the beginning and throughout the response. So I just wanted to highlight that.
Thank you, Eric. And we'll come back to some of the broader, I guess, political with a little p questions later. Mary, can I turn to you? We've heard it said throughout these three presentations that public health infrastructure has never been so stressed. And that COVID has demonstrated that, you know, the US just wasn't prepared. Mexico wasn't prepared, but the US wasn't prepared as a result of decades of underinvestment. How do we reverse this in ways that are evidence-based and non-partisan?
Thank you so much. It's a pleasure to join my colleagues on today's call. And I think this is an issue that has been made so clear during the COVID pandemic, that the vital role that public health plays in keeping societies healthy has been really stretched and pulled apart at the seams because of the underinvestment. And we know that the enormous costs of ignoring the health infrastructure has also been highlighted by the racism and the economic segregation that has occurred in low income and communities of color. And so you have this kind of, I'll say, double hit on public health that traditionally supports low income communities. And what we have is we've never seen across the board the level of devastation that has hit those communities. But long before COVID, we did have, you know, structural racism that created the conditions, particularly in these low-income communities, that cause serious health problems such as heart disease and high blood pressure and asthma and diabetes, which we all know are some of those underlying conditions that contributed to worse outcomes in populations that had chronic disease. So in COVID, we see that in Black and Brown communities where there's less access, where they have housing that is crowded and it's difficult for people to have paid time off. So they continue to have to work, and they don't have as much access to transportation to get to vaccines, and particularly for essential workers who don't have the luxury of staying at home. They have to continue to work. So all of those impacts have been devastating. And public health has not had sufficient workforce or resources to early on invest in stopping the threat of COVID-19, particularly in those highly vulnerable communities. Here in California, Native Hawaiians and the Pacific Islander communities actually continue to have the highest rate of COVID-19 cases, followed by the Latinx Californians. And the Native Hawaiian API community, Latinx and Black Californians have experienced the highest rate of COVID-19 deaths. So these are the same communities that, you know, have all of those vital conditions that are underinvested. So when we talk about underinvestment in public health, we're not just talking about governmental public health, but we're talking about the forces that undergird having a healthy public. And so unless we do something different after this COVID pandemic is over, we are going to have the same communities vulnerable to any pandemic that arises in the future. So we need the infrastructure that addresses all of this. We need to make sure that the investments are a short-term fix, but long-term infrastructure and a pathway to a different kind of public health, and one that I can say what we've seen are the trusted community messengers who are able to go into high impact communities and be able to educate people and convince them that the vaccine is safe and they should get vaccinated, is by the partnership between governmental public health and community-based organizations, by nonprofits working closely with community-based organizations. And I have to say, philanthropy has really stood up to be a partner also. So we have to change our concept, I think, about where the investments need to be made to support these vital conditions of health, and where the investments come from, because they have to come from multiple sources.
You know,
So
Mary, I just want
if I could just say one last thing, it should not be a political decision. And so you said, how are we going to change this? I have to say that I think we need to understand that the virus doesn't discriminate, and the social conditions that we have to address are going to have an opportunistic virus. So we need to think differently and work towards the good of overall society.
see what I was going to ask you, Mary. You just said that the virus isn't political, but in a sense, what we see from the two reports is that politics are absolutely public health. And I suppose the key message coming out of this briefing is that policy has to be evidence-led. One of the things I'm really keen we stop saying is that this is once in a century pandemic. There are all sorts of things that that have really made this a moment where we enter the age of pandemics. So I just want to pick up on a slightly cheeky thing that Neelam said to you, said to us all actually, about the, if we're evidence-based, should 50% of all governmental leaders be women? But isn't it fair to say that if we do look at the data, the leadership of women is actually a predeterminant of success?
Well, you know, I think we're going to have to look at this through a historical lens. I think there are a lot of studies that are showing that women leaders are doing a very good job in managing the pandemic in their countries. You know, leaders in Denmark and Finland, Iceland, New Zealand, Germany, Slovakia have been internationally lifted up and studied. But I think we're going to have to take a look at two things, that women leaders have been heroines for at many different levels, both the elected leaders and the governors. I would lift up also in the US that our women governors have had a better outcome in their states heretofore as well. But women are being pushed to the limits, and women are tending to have multiple jobs when they're at home, and they're often the essential workers, and many of them have lost their jobs. So I think while we're going to be lifting up the great leadership of these elected women leaders, and I think that they proactively communicated clearly, they made decisive actions to shut down and to include social distancing. But they also took a look at what the impact of the pandemic was having on families and put in place social interventions that were able to help people follow the rules that they were imposing. So I think
Mary,
go ahead.
I'm just keep it short.
Sure. I was just going to say, I think what we'll find is that there's a mix of women's leadership, and there are a lot of studies that show that women leaders have done well in business as well as in leadership as elected officials. But I think we also have to take a look at the countries and the culture that has allowed women leaders to thrive.
Thank you. Carlos, if I could turn to you. I want to ask you about how to empower and engage marginalized populations. Mary referred to them, Neelam did. What lessons have you learned in your leadership responding to the Southern HIV epidemic that you feel ought to be applied and adapted for people of color, particularly African Americans and Latinx? Carlos, you're still on mute. I'll give you a minute. Well, I tell you what, why don't we come back to Carlos in a minute? And meanwhile, we'll move on to Lucia. Lucia, you've been working with a lot of frontline healthcare workers treating patients with COVID. You've been looking and supporting them. A deep concern that many of us have in the policy environment is that, you know, we're potentially putting them at risk of burnout and exhaustion. How would we go about protecting them, would you say?
Well, yes, I'm a physician from Mexico. I have not been in the front line, but I've worked closely with frontline workers. Many of my friends here in Mexico are frontline workers, and I've seen firsthand how most of them have gotten COVID, how many of them have been severely sick with COVID. And there's a lack of response from the government. I'm talking right now in Mexico, there are no vaccines for doctors that work in the private sector. My friends that work in the public sector also have had trouble accessing vaccinations. So how do you protect them? Well, and this comes after a year of lacking personal protection equipment, where many of them had to pay for it out of pocket. So how do you protect them? Or first of all, you invest in them. It doesn't matter if they're residents, it doesn't matter if they're interns, you invest in your healthcare workers, and you treat them as the heroes they are. Second, I think you educate them, you teach them about COVID, and that's where we kind of came. I seeing how my friends were struggling, I decided to endeavor and start a project in which we every week we summarize the most important literature around how to care for COVID patients. We translate that to Spanish and we share it with our partners in Mexico and Latin America. So that's a second one, right? Educate them. And third of all, a very curious thing has happened here in Mexico, in which residents that, for example, one of my good friends, a dermatology resident, has not seen a dermatology patient in over a year now, and she's been in the ICU treating COVID patients. So what will this mean for our future doctors here in Mexico? So I think that's, I think that the main message is that if you treat them as the heroes they are, and you invest in them, you will protect them, but you will also protect the patients they're caring from.
Thank you, Lucia. And I see we've got Carlos back. Bit of a storm passing through that affected the internet infrastructure.
Yes, exactly.
That tells you something, doesn't it? So I wanted to ask you, Carlos, about how to empower and engage marginalized populations. Your leadership in tackling the Southern HIV epidemic. What are the lessons learned that could be applied in this circumstance for people of color?
Well, thank you very much, Ben. I think that there's several things that we have learned from how do we approach the HIV epidemic that are applicable to COVID. Number one is, you said exactly, it's empowering, right? Make the community be part of the solution. Work with the community and include them in the decision-making process. I think, you know, for example, when we're talking about increasing vaccination rates, we have to work with the community. We have to ask the community, who are the best people to get you interested in vaccine? How do we get vaccines to you? How do we increase vaccine acceptance? And then you work with those communities to do that. It is a slow process, but again, it's a process of building trust. And trust is something that doesn't happen overnight. You have to slowly make it happen. And the other thing that we have to do is, you know, marginalized communities, we frequently go to them when we need them, and then we leave them after that. And I think what I think COVID, we need to do as a country is we need to really develop a contract, a long-term commitment to improve the health of the community. This is not simply about getting you vaccinated and we'll see you later. This is really about how do we improve access to primary care? How do we improve access to healthcare in general? I'm in a state that has an expanded Medicaid. I mean, why haven't not we expanded Medicaid? What are the kinds of things we need to do to make you be more likely to be benefited from healthcare like everybody else can?
So you were an investigator on the Moderna trial, Carlos, the vaccine Moderna trial. How were we able to go from lab, and I'm sorry for the plug for my podcast, but from lab to a shot in the arm in under a year? What was that like?
Well, we were able to do it because we built on what had happened in the past. Number one, the US, as opposed to many other countries, the US invests heavily on basic research. And I think basic research paid off, right? In 2003, we had a SARS epidemic. It didn't come to this country that much, but during that SARS pandemic, that first virus that caused an epidemic called, severe adult respiratory syndrome that killed many people globally, close to 1,000 people globally, a lot of people started working on a SARS vaccine, which was never deployed. But when the COVID virus was discovered and it was realized that it was very, very similar to the SARS virus, and it also used the same receptor, the ACE2 receptor from the spike protein, then all that work that had been done for SARS could be rapidly translated into work for this new virus, a new vaccine. And then finally, it's all the work that many people, including investigators at the NIH Vaccine Research Center, had been doing, developing vaccines using a platform called mRNA. And again, the NIH Vaccine Research Center was put there to develop an HIV vaccine. But the work they were doing towards finding an HIV vaccine has proven to be helpful for Zika, has proven to be helpful for Ebola, and now proven to be helpful for SARS-CoV-2. So we're talking about building on a lot of research. So you're not starting from zero, you're really starting from 6 or 7. And then after that, once the genomic sequence was understood, then it was pretty easy to get that piece of genome of the virus and put it inside the platform, whether it's an mRNA or an adenovirus vector, and then start developing that and then rapidly testing if the vaccine produced antibodies. And if it produced antibodies, then rapidly moving into the human trials with the vaccine. I would tell you that, to me, the most amazing thing has been how safe these vaccines have been, but also how incredibly effective they have been. If you go back in past, you'll realize that when the first request to apply to vaccine, desire to go forward to vaccine trials to the FDA was made, the FDA said, we're looking for a vaccine with about 60% efficacy. I don't think anybody was even dreaming about a 95% efficacy that we're seeing with these vaccines. So the efficacy we've seen and the safety of these vaccines, to me, in the midst of a very complicated year with a lot of disappointments, has been the most wonderful news we've had all year.
Thanks, Carlos. Lucia, can I come back to you very, very briefly? As you look at these two reports, how have they influenced, here you are at the start of your career, how have they influenced what kind of research questions you wish to develop?
Yes, so I've also been doing research with Spanish speakers in San Francisco, and as Jaime and others have mentioned, the Latinx population has been disproportionately affected. But we can say the same thing about the Latin American countries. We know that 35% of deaths of COVID are in Latin America. So I think that's kind of where my main questions of interest is, how do we include Latin America in the global health response? We're seeing a lot of uproar with what's happening in India, and it's fair, it's crazy what's happening in India, but similar things have been happening in Latin America. So I think there's a very big role that Latin America has to play in the sphere of global health. And similarly with the Latinx population, where I live in San Francisco, even though I'm Mexican, and how these people, a lot of Latin Americans, immigrants in San Francisco, have been experiencing this double burden of the pandemic, right? They're seeing how people, their own families dying in their countries of origin, many people of who I speak of, and they're also disproportionately being affected in San Francisco. So how do immigrants manage this dual pandemic they're living in? And I think it's, I don't know, it's very inspiring population to work with. Not only have they been more affected by disease, but also economically, yet they're still sending remittances to Mexico, to Guatemala, to Central America. And I think this is inspiring, and I think we need to turn around, turn south, and help out Latin America, help out the Latinx community. And that's where I want to really focus my research on.
Thank you. Jaime, could I come to you for two quick questions before we go to the floor to get some? These two reports, they are fascinating. There's something so telling about, epidemics in two neighboring countries separated by one boundary. I'm sure many of us here think of ourselves as card-carrying citizens of everywhere. But can you think of a situation where borders are actually a good thing to help prevent pandemics? You're on mute, Jaime.
Right now at the US-Mexico border, Ben, we're facing a very critical situation. I think it has to do with remnants of the Trump administration and cruel policies of family separation, of remain in Mexico policies for asylum seekers. So those policies are not easy to be reversed by executive orders, even though the Biden administration has been working very intensively on that. But we know that migrants have had a particular hard exposure to COVID and other communicable diseases while waiting in crowded shelters at the border. Right now, we're doing a study in Tijuana, and we already see much larger rates of COVID exposure measured by antibodies than the rest of the population. So I think the Biden administration is focusing now more on the root causes of migration from Central America and trying to have more humanitarian policies to asylum seekers. So the border, I think, is an opportunity, and it is also a crisis at the moment. So we share a very long border. There was a wall constructed by the previous administration trying to separate countries, while at the same time, economically, we're now more integrated than ever. So I think we have to think in a larger perspective with migration as an opportunity, of course, secure, controlled, and ordered migration. And the border is one area that the US is now finally paying more attention to.
Now, you've mentioned it, and Lucia did as well, the rates of infection happening in Central and Southern America. What are the public health implications for both Mexico and the US of this?
Well, what I would hate to see as a consequence of migration is that migrants are perceived as vectors of disease. That is not the case. So we have to combat that impression because, as I mentioned, migrants are a tremendous economic force, and we have to be more inclusive and certainly look for an ordered and secured immigration from Central America and Mexico.
Well, let's now open the floor. If I could ask all the participants to come back and switch their videos and mics on. We're going to take some questions that have been submitted through Zoom and through the Facebook Live. And the first one is really about vaccine hesitancy. And we've had two questions come in. An anonymous attendee asks us about the anti-vaxxers that are so well known to us in parts of our own area, the progressives living in Northern California, and what do we do to speak to them and to get them more willing to consider vaccines? And there was a related question that came through Facebook Live, which was about some folks in Mexico believing that the vaccine was designed. And are there any recommendations about how we provide accurate information to COVID? This is something, of course, public health is about messaging, communication, and advertising. And I would really love to get a couple of folks' views on this. And maybe we could start with Eric Goosby. Eric, you've been dealing with misinformation about HIV domestically and internationally throughout your career. Very briefly, what should we do about vaccine hesitancy here coming on from these reports?
Thanks, Ben. I think that we are obligated to continue to try to meet those who have reservations about accessing the vaccine with identifying their concerns and trying to unpack them to explain why this on a risk-benefit level is so clearly to their benefit to get it, and to also explain kind of the shared responsibility that being vaccinated introduces to an individual toward the larger population through the herd immunity impact and a desire to achieve that. I think as we move into the so-called vaccinated passport discussions, which the private sector is taking very seriously, as well as many schools, institutions, as a lever to play to minimize the population that comes back to either the workplace or to school, but also to have strategies that keep it that way. And I think so a high desire to identify and maintain a discussion with those who are fearful of getting the vaccine. But I think the passport need and the opening up of behavior pre-COVID, travel, entertainment, is going to push a lot of people into compliance with the vaccine. I think our role is to continue to educate and to let that play out. And to that end, I think the CDC would be strategic to start talking about the reopening of the recommendations that they have done over the last 10 days or so to connect those dots for the population better. Passport, travel, return to pre-COVID lifestyles.
Wow, that also suggests perhaps a key role for the travel industry in contributing to that. And that sort of brings us on to a question we got from James Allen. And I'd like to put it to the two authors of the reports, Neelam and Mariano. We didn't talk about this quite so much in the presentations, but the role of private sector contributions to pandemic responding can be seen as episodic at best. What barriers exist in the academic and public health communities which prevent engagement with the private sector? Neelam, maybe we could start with you.
Thank you, Ben. That's a great question. I think that traditionally in academic and public health communities, we have not seen the private sector, which is really basically most of healthcare in the United States, or the private sector more broadly, like organizations, companies, as our partners. And we haven't really brought them into our strategies. And I think we really need to do that more. I mean, in the Bay Area, some of the first organizations to take strong public health measures were tech companies who said, you now need to work from home. And they closed down long before the public health agencies said we needed to shelter in place or we needed social distancing. So I think that actually has to start now on an ongoing basis to create some forums for public health people, private sector people to come together and find solutions to these very large problems that are significant.
You know, Ben, for me, if I could just add to Neelam's comment, the lack of central authority in coordinating a local response across public and private sectors needs to be understood and fixed. Our inability to have that conversation for weeks, for the private sector, which, as we've alluded to, makes up 93% of the insured of the population is insured. They are responsible for this. That should be understood, worked out in the way of the specifics, and relative investments harmonized, so we aren't all investing in the same thing at the same or the wrong time, but are synergistic, additive, etc. We can do all of that, but the private sector has major disincentives to engage, and mostly profit margin threats. And until there is an epiphany of the shared responsibility and that it is not okay to take a essential need such as healthcare for either life-saving or life-sustaining interventions and make it available or more available to segments of the population, depending on how well their labor, their workplace reimburses their health insurance. I mean, so all Mariano, of those discussions.
I'm going to absolutely, and you and I have been in this.
And we have.
Mariano, I'm going to come to you in just a second. But Sandra Hernandez asks a good question, Eric. I want to see if you can just put one sentence as a response. What's the remedy for the fact that health insurance did not and does not seem to have any relevance in responding to the pandemic such as COVID-19?
I think the population, I think it'll come from the profession holding the insurance companies responsible and the population itself. The people need to say, this was a foul that we saw, we understand, and we need to correct. Without that, the political will to engage is really low for all the reasons that I know this group knows.
Okay, Mariano, role of private sector in Mexico, briefly.
Well, I should say that some of the most successful experiences in managing the pandemic in Mexico, one of the few we could say, where when the government collaborated with the private sector in setting up institutions or new forms to take care of patients, especially in Mexico City. Now, unfortunately, this experience was not replicated on a larger basis. And I think the lesson here really for the future is that national governments cannot and should not be left as the sole responders to health emergencies, especially in countries like Mexico with very high out-of-pocket health expenses. So we need to find ways to institutionalize cooperation between the public and the private sector. Now, in terms of adapting and strengthening the broader public health system, this really creates a conundrum in the sense that it is wealthier citizens who have the resources to have a private health insurance and seek care in private hospitals that get better care, and therefore you don't have the constituency to really fund the reforms that you need to strengthen the public sector. So that's why national governments should really play a very strong stewardship function and play their role in trying to coordinate during the health emergencies, this collaboration, and try to put together the coalitions that you need to look at at access to public health as a citizen right and strengthen systems regardless of whether people have the money or not to cover for or pay for private insurance.
Okay, Mariano, thank you very much. We've reached time, I'm afraid. This was a very full, rich conversation, and there was a load that I really wanted to get in there. Jaime, could I hand over to you and to our Bay Area Global Health Alliance Chair, Mary Pittman, to close us out and to put a pitch for the Alliance as well?
Thank you, Ben. Let me just say very briefly, the World Health Assembly will take place in a few days in Geneva, and the independent panel will be presenting the conclusions and recommendations. Our 2 case studies were ranked the best of all the contributions solicited by the independent panel. So we're proud of that, and we hope this will have an impact on understanding what went wrong and why, and what are the lessons learned for preparing for the next pandemic. Finally, I think this is an opportunity once in a lifetime for the world to really go back to humanitarian and globalization in a big way, so that we go away from the nationalism that has been so prevalent lately. This is an opportunity to help every nation, to make sure that every person gets vaccinated as the only way to get out of this nightmare. Mary.
Thank you, Jaime. I want to thank everyone on this event today. It truly is an honor for the Bay Area Global Health Alliance to be joining with Jaime and the authors of those really incredible reports. I do want to say that while the Alliance started before COVID, this has provided an opportunity for nonprofit organizations, academics, and the tech companies in particular to come together for this kind of cross-learning. And just recently, we've seen how beneficial that's been as we're mobilizing to try to identify some opportunities to support all the work that's needed in India. So Ben, I'm going to turn it back to you, but anyone who wants more interest on the Bay Area Global Health Alliance, I encourage you to reach out. We welcome you.
Well, with that, it just remains for me to thank everybody who participated in this call. Thank you to everybody who asked questions. I'm sorry we didn't get to everybody. And I just want to wish you all a good week and a safe week. And please keep India in your thoughts, and please keep the growing infections that are happening in South and Central America in your thoughts, and no doubt in all of your actions. So thank you so much indeed for joining us, and have a great afternoon.
Bye now.